We're excited to introduce a series of rapid-fire presentations featuring select abstracts submitted to this year's symposium. First of all, I want to thank everyone for submitting their abstracts and bringing their posters today. Hopefully we can continue growing that into next year to continue sharing some of the great work that's being done across the country. These short, high-impact talks highlight emerging research and clinical insights across pain, harm reduction, and medical cannabis. We encourage you to note any follow-up questions during the networking sessions right after. So for our first presenter is Rahim Dhalla, a pharmacist who will be covering conventional versus cannabinoid treatment for pain management in patients with provoked vulvodyni. Welcome.
Thank you very much. I'm excited to be here, guys. My name is Rahim Dhalla. I'm a pharmacist and former owner of Hybrid Pharm, which was my compounding pharmacy out in Ottawa. It was a retail compounding pharmacy, and I had a medical sales license with possession. So I was able to distribute cannabis on site with patients who had prescriptions. So as you can imagine, I've seen a lot of different patients, a lot of different cases came up, and I wanted to present something here today for you guys. What we took was 9 patients, 9 women with provoked vestibulodynia. This is a chronic, it's a chronic vulvular pain syndrome. It can be generalized or provoked. So when it's provoked, it's upon touch or any type of insertion. And this usually affects up to about anywhere between 8 to 28% of women. But because of the complexity of this disease state, it normally goes undiagnosed or misdiagnosed, and it's very hard to treat. Symptoms of this can be burning, stinging, pain, dyspareunia, pain upon sitting, pain upon touch, pain upon even wearing tight-fitting clothing. The current treatments that we see, and I've seen in the pharmacy a lot, we are looking at tricyclic antidepressants, maybe gabapentinoids, anticonvulsants. And again, due to the heterogeneity of this disease state, we are starting to see multimodal approaches, so baclofen diazepam suppositories. So we're taking a lot of different components and bringing them together. And again, this has kind of led to the rationale of why did we want to study, cannabinoids versus conventional, because of the failure rate with conventional medication. A lot of these patients were failing pharmacotherapy. The current treatments that existed on the market were causing side effects and unwanted issues. And also, because of the endocannabinoid system, as most of us in this room know, how it works, why it works, THC and CBD combination may have an effect. And as we know of the location of endocannabinoid systems and the CB1 receptors, they're very abundant in the reproductive system. So this is why this is our objective here. We wanted to take a look at, what are we're going to compare the cannabinoid therapy versus the conventional therapy. So 9 participants were in our study here. They were randomly assigned to 1 or 2 groups. One being the conventional therapy, which is the baclofen diazepam suppository with or without the hydrocortisone and clotrimazole cream. And the other one was the cannabis therapy. So we took a 1-to-1 oil found on the market, and we actually compounded that into suppositories. So it ended up being about a 12 milligram to 12 milligram CBD to THC vaginal suppository. We then gave these participants a baseline VQ questionnaire. This is a vulvular pain questionnaire. This was given at baseline, then 1 week, 2 week, 3 week, 4 week, 8 week, and 12 week. So they weren't able to get the next dose until they filled out this form. So we just kind of collaborated all that data, and what we found was an overall pain reduction in the cannabinoid therapy was 65%. So by week 4 versus conventional 38%. And I'll have to make a note that the baseline pain rate scale was a bit higher in the cannabinoid group versus the conventional group. We also noticed a kind of impactful data set between the pain while sitting. So patients in the cannabinoid group ended up having full resolution within about 4 weeks, versus with the conventional group took about 12 weeks to resolve. Side effects were mainly noted in the cannabis group as fatigue, but they were well tolerated and transient. Again, with most studies in the cannabis field, the limitations were a small sample size. We only had 9 patients, so we can't really generalize this on the full population. And also, patients were self-reporting this. So they were sitting in my pharmacy, filling out the VQ questionnaire, trying to recall, oh, do I have pain? Do I have this? Do I have that? And that can also, shunt a little bit of these statistics. So recall bias, and patients were not blinded. So they knew what they were getting. They were either getting conventional or cannabis. So again, that could also play into a factor of how well they responded to therapy. So again, and also because I compounded this at the pharmacy, there could be a little bit of product variation between the strengths of actual medication were found in each suppository. So obviously, in conclusion here, we did notice, an interesting trend that these patients showed greater and faster improvement on their pain and symptom relief. Adverse effects were mild and transient. But again, like almost everything in the cannabis field, we obviously need more research and more robust clinical trials. Thank you.
Thank you, Rahim. Next up is Martha Lopez-Canua from McGill University, who will focus on putative mechanism of action of the effect of cannabidiol in insomnia associated to neuropathic pain and firing activity of on and off neurons. Welcome.
Thank you, everyone. So my name is Marta Lopez. I'm working with Dr. Gobbi at McGill University. And today I'm going to present this part of our project, which is the mechanism of action of the cannabinoid in insomnia related with neuropathic pain, and also the downstream mechanism of action of on and off cells. So, Okay, so I just have a small disclosure here. So Dr. Gobbi and we possess the patent for the use of cannabidiol for the treatment of insomnia associated with neuropathic pain. Very briefly, I just want to say that, mention what is neuropathic pain, which is a chronic disorder resulting from a damage of the nervous system, and up to 50% of the patients, they experience sleep disorders, and these sleep disorders exacerbate the neuropathic pain. This exacerbation of neuropathic pain also impact one more time in the sleep disorder. So, and only with the problem is the only small number of effective drugs are available for both. That's why we need and we encourage with the research in this area. So one important mechanism of action here with all analgesic works is in this part of the midbrain in the rostral ventral medulla. So there is 2 different kinds of neurons there. One is called on cells and one is called off cells. They have opposite effect for a pain sensation or for a pain stimulus. On cells increase, meanwhile off cells decrease, and all the analgesic, they decreases the on cells and increase the off cells. So that's why we want to know what is the effect here with cannabidiol. So for these are our objectives. So we want to induce neuropathic pain. We use a model of rats. We induce through a spare nerve injury. Then we want to assess what is the effect, the different doses of CBD. The second objective is to characterize the effect of this neuropathic pain in sleep, and if we can see if the doses of cannabidiol reverses sleep impairments while reducing neuropathic pain. Also the effect or what is the mechanism of action in the on-off cells in this nociceptive pathway. And this effect on sleep and on pain can be reversed or can be blocked by serotonin 1A receptor antagonist. So this is our methodology. I'm going to go very briefly here. It's all explained in my poster, but we induce neuropathic pain here, which is surgery, and then the animals went 15 days. They were left 15 days for recovery. After this, we assessed mechanical allodynia. Only animals who develop mechanical allodynia were placed in 3 different cohorts. The first one, we assessed neuropathic pain with different doses of CBD. The second one, we implant electrodes on the skull to assess the sleep with EEG and EMG recordings. And the third cohort, they undergo to electrophysiology. And this is our results. These are our results so far. So in the first part of our objectives, we can observe that the animals here, we test CBD in a doses of 5, 10, and 20 milligrams per kilogram. And we can observe there is like a curve dose response with a best effect with the CBD 20 milligrams per kilogram. This animal with neuropathic pain then, so we also administrate whey 10 minutes before the CBD to see if this effect on pain can be blocked by this serotonin 1A antagonist. And we can observe here on purple that it is partially blocked. In the second part, in the sleep parameters, we can observe that the animals with neuropathy, which is here in the bars in black, they decrease the REM sleep, decrease the non-REM sleep, and they increase the wakefulness time. And at administration of 20 milligrams per kilogram of CBD, they can recover this at the levels of naive animals. Again, we want to administrate the whey, the serotonin 1A antagonist, to see this effect of CBD we can blocked, and it's exactly what we can observe here. So they block the effect in REM, non-REM sleep, and a wakefulness time. Lastly, in our electrophysiology cohort, we can observe that in an on-cells firing activity, administration of CBD reduces the activity of these neurons, which is what we were expecting. And on the contrary, in off cells also decreases the firing activity. So this is some of the contradictory results that we found, and we want to keep working on this. Well, this is exactly what I was mentioning about our conclusions. And then I just want to acknowledge the people from our laboratory. Thank you so much.
Thank you. Next up is Ika Washington from York University, addressing clinical evidence gaps in cannabinoid-based medicine for Black and racialized populations.
Hi everyone. There we go, that way. Okay, hi everyone. So my name is Ika Washington. I am a doctoral student at York University. I'm also a medical cannabis patient for chronic pain as well. And a lot of the work that I focus on is in working with racialized communities and marginalized communities. I also wanted to do a disclosure that a lot of the work that we're doing has been funded and supported by the Ontario Cannabis Store, as well as a lot of community-based partnerships as well. All right, so I wanted to do a short reflection. I think it's only timely, especially given the content that we're going to be talking about today. And I wanted to recognize that the ongoing impacts of colonialization, as well as including within healthcare systems in itself and drug policy, as well as in terms of research practices as well. And this is where my work is really committed to addressing as well, and trying to find ways that we can best align in terms of looking at the best ways to approach medical cannabis for patients, especially those that are racialized, that do come from a history of having hesitations around how to access medical cannabis in itself as well. All right, so in terms of bridging the equity gaps in terms of cannabinoid medicines, what we had done was actually do a rapid review in terms of understanding the actual issues in terms of relevance in terms of clinical trials, and also just in clinical and healthcare settings in itself. In terms of our work initially was actually looking exactly at the clinical trials and also real world data in terms of what is actually collected in terms of race-based data collection. As we know, Canada has limited access in terms of race-based data collection collection, so it made it very, very challenging. So we did actually look at other communities and other countries, but also recognizing in terms of clinical trials in itself that aspects of cultural stigma, also medical racism, as well as cannabis in terms of criminalization, also shape access in terms of disclosure, as well as treatment outcomes for a lot of racialized and also Black populations in itself. And within this study, we also integrated a lot of the work that we did in terms of our most recent event, looking at reclaiming narratives. And this is where I brought ethnographic research into it. I am a qualitative researcher, and I'm a critical health sociologist at Self. Okay, so what we really wanted to understand, especially when we're looking at the landscape of medical cannabis in itself, is what are the consequences of using culturally unsafe practices in terms of clinical settings and when we're discussing cannabinoid research. We were also concerned about and trying to understand where and how do racialized populations represent in medical and clinical cannabis research. Also, do interventions account for the structural determinants in terms of racism, criminalization, as well as stigma, and really trying to understand what does stigma mean for these communities as well, because I think that oftentimes we use this umbrella term, but it can mean very differently for different populations, right? And then also trying to understand how can community-led models challenge dominant clinical assumptions in order to actually integrate and to see more racialized individuals that need these types of therapies that I actually benefit from as well. So again, we're doing a rapid scoping review using Cochrane methodologies. It's an ongoing process right now in terms of trying to get more data. We're looking at peer-reviewed articles in terms of studies and also looking at policy documents and great literature in itself. And then our focus is really around equity principles, looking at race-based data collection methodologies and ethical concerns around that as well, and also looking at culturally responsive design. In terms of our ethnographic case study, it is one that we're looking in terms of grounding different methodologies in terms of hip-hop as one of the methodologies to have these conversations with communities. Also looking at trauma-informed facilitations and looking at storytelling. For that, actual work in itself was primarily with Black populations. And then also looking at community insights in terms of grounding and actually co-designing this work moving forward as well. So overall, from our key findings thus far, we've looked at that obviously the majority of the research that is there right now is actually limited in terms of or omits race and ethnicity. Also, there's fewer disaggregated outcomes that happen in terms of clinical research around cannabinoid research. Also, there's a few, if not very limited amounts of interventions that actually address stigma and actually community mistrust and distrust in looking at historical harms. And then we're also looking at the fact that community models offer alternative pathways where people are actually using cannabis as coping mechanisms and actually in the ways that, in terms of actually addressing the ways in systemic structures are actually failing them, especially around culturally appropriative care. And then also, I'll just actually skip past because I'm short for time, but what I've noticed and what we have noticed in terms of our team and the work that we've done in terms of actually doing the event where we actually looked at the history of cannabis since its introduction to Africa and following through and having that as an opening discussion was actually looking at the fact that there is structural change and that a lot of the issues that around stigma for Black populations, for example, is really not only starting from prohibition, but it's actually starting from the introduction of cannabis as a cash crop through the political economy of the slave trade as well. So there are conversations that are being had around the actual use of cannabis throughout our histories, but also looking at the fact that this actually does bleed into our clinical models and how people are actually accessing care and their hesitations to access care in terms of barriers as well. So this is where the aspect of cultural safety as well as cultural congruency is actually important in terms of embedding it within our clinical trials and how we approach that, but even more so within healthcare settings, actually addressing what medical racism looks like actually in terms of also addressing the ways in which we should be approaching these populations in terms of care, in terms of health promotion as well. So I just wanted to leave with this quote, and it's one from Dr. Navarro, who is a well-known political scientist and sociologist, is saying that it's not inequities that kill people, it's those who are responsible for these inequities that kill people. So we really do need to take in consideration the ways in which we approach care, especially for populations that are undergoing different systemic issues in terms of cannabis as well. And thank you.
Thank you to all our speakers and presenters for an exceptional third session of the day.